This is a concept video on Pheochromocytoma and Paraganglioma. Pheochromocytomas and paragangliomas are neuroendocrine tumors that arise from chromaffin cells, either of the adrenal medulla or of the ganglia of the sympathetic nervous system. Since pheochromocytomas and paragangliomas are capable of secreting catecholamines, these tumors can be explosive in that their production of alpha and beta adrenergic agonists can result in major symptomology. These include cardiovascular symptoms and diseases, psychiatric symptoms, and an overall decreased quality of life. Further, pheochromocytomas and paragangliomas can be a part of genetic or inheritable tumor syndromes that may be associated with other tumors, may have malignant potential, and therefore should trigger important prognostic and surveillance implications. In fetal development, the adrenal gland is formed from neural and mesenchymal components. Mesothelial cells form the fetal adrenal cortex. Neural crest cells migrate ventrally to form the sympathetic ganglia, chromaffin cell clusters, and the sympathetic nervous system. Neural crest cells continue to migrate ventrally and merge with the adrenal cortex to form the adrenal medulla. Thus, the adrenal gland is composed of two distinct embryologic origins: neural crest cells that form the adrenal medulla, and the cortex is of mesenchymal origin. Tumors that arise from the adrenal medulla are called pheochromocytomas. As we just learned, the sympathetic nervous system is also composed of chromaffin cells, and tumors that arise from the sympathetic ganglia are termed paragangliomas. Extraadrenal paragangliomas can arise in the head and neck, the chest or mediastinum, as well as the abdomen and pelvis. In addition to the anatomic differences between pheochromocytomas and paragangliomas, there may be biochemical differences also. Catecholamines are synthesized from a tyrosine substrate to produce levodopa, dopamine, norepinephrine, and epinephrine. Notably, these catecholamines are neurotransmitters in that they are used by the brain and autonomic nervous system all the time. An important distinction to be aware of is that although most catecholamines can be synthesized in the brain and sympathetic nervous system, the enzymatic machinery to synthesize epinephrine is exclusive to the adrenal medulla, and therefore only the adrenal medulla can synthesize all of these catecholamines, including epinephrine. These catecholamines have short half-lives, may have variable secretion patterns, and usually exist in very low concentrations in the circulation, and therefore we do not typically measure circulating catecholamines. However, catecholamines are metabolized into inactive and stable intermediates called metanephrines. Epinephrine is metabolized to metanephrine, and norepinephrine is metabolized to normetanephrine. These metanephrines can be reliably measured in the blood and serve as a sensitive marker of catecholamine synthesis. Metanephrines are further metabolized to vanillyl mandelic acid and then excreted in the urine. Metanephrines can also be conjugated, which is essentially a sulfation process, and also excreted in the urine. Here we have a cartoon illustrating catecholamine secretion in real time. The gray figure represents the adrenal medulla. The yellow figure represents a sympathetic ganglion. The adrenal medulla can secrete norepinephrine, but only a small fraction of circulating norepinephrine can be traced back to the adrenal medulla. In fact, the vast majority of circulating epinephrine comes from the sympathetic nervous system. Since norepinephrine is metabolized to normetanephrine, a small fraction of circulating normetanephrine is from the adrenal medulla, whereas most of it represents sympathetic nervous system activity. In contrast, only the adrenal medulla can secrete and synthesize epinephrine. Therefore, all circulating epinephrine is sourced back to the adrenal medulla, and similarly, all metanephrine in the blood are due to adrenal epinephrine source. Therefore, elevated blood levels of normetanephrine could signify a pheochromocytoma or a paraganglioma or heightened sympathoadrenergic tone. But elevations in metanephrine strongly suggest an adrenal pheochromocytoma or increased adrenal medullary activity. The clinical manifestations of a catecholamine tumor can be severe. They typically occur as paroxysms or spells, a sudden burst of a constellation of symptoms that reflect excessive alpha and or beta adrenergic receptor overactivation. These predominantly include cardiovascular manifestations such as tachycardia, palpitations, episodic or sustained elevations in blood pressure, chest pain, and with chronic catecholamine excess, cardiomyopathy. Symptoms can also be neuropsychiatric in nature, including anxiety, panic, and headache, especially when hypertension is severe. Other manifestations include sweating, tremulousness, and abdominal pain. As an example, here are the blood pressure readings of a patient over the course of 20 years. The systolic blood pressure is seen to range mostly within 120 and 140 millimeters of mercury. However, a similar recording of the same patient's blood pressure 15 years later shows much greater lability of blood pressure, with systolic blood pressures ranging from 120 to 180 millimeters of mercury, and occasional readings even higher than 180. This patient is actually Dwight Eisenhower, the 34th President of the United States, who experienced episodic hypertension and adrenergic symptoms, and died of ischemic cardiomyopathy after suffering numerous myocardial infarctions. On autopsy, it was discovered that he had a 1.5 centimeter pheochromocytoma, which was considered to have been the probable cause of his paroxysmal cardiovascular manifestations. So how does one diagnose a catecholamine-producing tumor? In the setting of suspicious adrenergic symptoms that raise the concern for pheochromocytoma or paraganglioma, detection of elevated plasma or urinary metanephrines can confirm the diagnosis. Measuring metanephrines has a very high sensitivity, meaning if a patient truly has a pheochromocytoma or paraganglioma that is functional, they will almost certainly have elevations in metanephrines. However, the specificity of these tests is 85 to 90%, meaning that 10 to 15% of patients who do not have a catecholamine-producing tumor will have elevations above the upper limit of the reference range of metanephrines, in other words, a false positive. Minor elevations above the upper limit of reference ranges of metanephrines are not indicative of a true catecholamine-producing tumor. True pheochromocytomas and paragangliomas that induce a detectable clinical syndrome have substantial elevations of metanephrines, at least twofold above the upper limit of reference, but usually fourfold or higher elevations in metanephrines. This cartoon reviews the physiology of catecholamine secretion, metabolism, and the cause of false positive elevations in metanephrines in the absence of a true catecholamine-producing tumor. This yellow cell represents either an adrenal medullary cell or a presynaptic neuron of the sympathetic nervous system. This blue cell represents an end organ cell or a postsynaptic neuron of the sympathetic nervous system. Catecholamines such as norepinephrine and epinephrine are synthesized in the adrenal medulla or presynaptic neurons. Catecholamines can be increased in the context of a high sympathoadrenergic tone, either due to increased stress or illness. Also, catecholamines can be increased in patients who are actively using sympathomimetic medications, such as levodopa or infusions of dopamine or norepinephrine. Catecholamines are in part metabolized by the monoamine oxidase enzyme. Therefore, medications that inhibit monoamine oxidase can result in increased catecholamine levels. Once catecholamines are secreted, they have two fates. One, they can be reuptaken by the presynaptic neuron or adrenal medullary cell. Therefore, medications that inhibit the reuptake of catecholamines can cause false positive elevations in catecholamines and metanephrines. This is an important source of false positives since the use of norepinephrine and serotonin reuptake medications is prevalent. Alternatively, catecholamines can bind to adrenergic receptors. Therefore, the use of alpha or beta adrenergic receptor antagonists can cause mild elevations in catecholamines and metanephrines. The treatment for pheochromocytomas and paragangliomas is surgery to remove the source of catecholamine excess. Preoperative medical treatment is necessary to substantially reduce the risk of operative and postoperative complications. The goal of preoperative medical therapy is to block peripheral effects of catecholamines to minimize excessive intraoperative alpha and beta adrenergic agonism that may result in severe hypertension and tachycardia that could cause end organ damage, while simultaneously minimizing the risk for postoperative hypotension. Therefore, the key components to preoperative management include the identification of a surgical and anesthesia team that has ample experience in the hemodynamic complications of removing a catecholamine-secreting tumor, treatment with alpha and beta adrenergic receptor antagonists, and volume expansion with salt or saline, since catecholamine excess induces a natriuresis and volume depletion that can increase the risk of postoperative hypotension. This concludes our brief review of pheochromocytomas and paraganglioma.